Good day, I'm Sherilyn Francis with the National Center for Primary Care, and we welcome you to Part 5 of our Opioid Use Management webinar series. Additionally, we invite you to connect with us via social media at pricarematters.org and via the website at www.primarycarematters.org. The National Center for Primary Care is located at the Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in underserved areas. The core principles of the NCPC are effectiveness, access, and equity. Today's webinar is made possible via a partnership between the Southeast Addiction Technology Transfer Center and the Recovery Institute of Southwest Michigan. The objectives for today's webinar are to identify best practices for treating opioid recovery, to review the standard guidelines and protocols for treating patients in recovery, to identify lessons learned for public health professionals working with patients in recovery, and to examine peer support networks in the recovery continuum. Today's webinar is CME accredited. In order to receive CME credit, a registrant must attend the entire webinar. A registrant must complete the CME form, which will be emailed within 24 hours following the webinar, and all non-Morehouse School of Medicine employees must submit a payment for each CME certificate. I now present to you today's webinar entitled Paving the Path to Opioid Use Recovery Paving the Path to Opioid Use Disorder Recovery, presented by Dr. Jean Bonhomme, Public Health and General Preventive Medicine, Clinical Assistant Professor, Psychiatry, Morehouse School of Medicine, and Jamar James, Victory in Recovery Team Leader, Recovery Institute of Southwest Michigan. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturer of any commercial service discussed in this educational activity. And we'll begin with the recovery testimonial from Jonathan. Would you mind sharing how your addiction began?
Yeah, my addiction began as I had some medical problems with my back, and I was prescribed opiates. And then my dosage changed, and I didn't realize it, and it gave me that high feeling. And pretty much as soon as that happened, it was uncontrollable. Like, it just kind of took over my state of mind. That was what I needed to get. Eventually, it led into other opiates, stronger medications, because my tolerance was going up. So I was getting it anywhere I could, from the multiple doctors to on the street, wherever I could get it.
Thank you for sharing. And what sparked your recovery?
I had wanted to get into recovery for a while, and I had made multiple attempts, but my recovery, unfortunately, I had my kids taken temporarily, and but it's actually been a good thing because it's been able to let me focus on myself and fixing the problems that I have.
Okay, and have you experienced relapse during your recovery journey?
Yes, I did.
And can you share your experience with relapse and what put you back on the path to recovery?
Yeah, I'm going through a divorce after 11 years, and it was a toxic relationship. We both were addicts, and there was a point where I actually tried Suboxone, and I was off of everything for 3 months, but because my wife was still using and still living the lifestyle, eventually I just fell back into it. So in my most recent clean time, I've completely changed my whole way of thinking because I learned through NA that if I don't change my complete way of thinking, then I'll go back to using.
Wonderful. And just to make sure that we're driving this point home, which factors have aided in sustaining your recovery?
Um, Therapy sessions with a therapist, a lot of group sessions. I do NA every day, and I do a lot of literature reading. I also have a sponsor and a recovery coach that I get a hold of my sponsor every day, and if I have any issues, I can call him at any time. And I also have a recovery coach that I can talk to at any time. I've also been in constant contact with my doctor to keep up on, like, my psychological and medications that I need to be taking in my health care.
Wonderful. Thank you. And as a closing thought, before we transition to Dr. Banam, are there any last thoughts that you would want to share in relationship to recovery with the health professionals who are currently attending today's webinar?
One thing that I definitely want to say is that I'm living proof that any addict can change and stop using, find a new way to live, and be happy. But also, I would recommend that any doctor prescribing any medications needs to, like, really drive home the fact that, like, they are addictive, and the side effects that come along with coming off of the medication, because that was my biggest fear, was the withdrawal.
Thank you so much, Jonathan. And for the audience, Jonathan will remain through the duration of the presentation and will be available during question and answer. And now, Dr.
Good afternoon, everyone. We're going to talk about the role of the primary care practitioner because the opioid epidemic, and being as widespread as it is, some of it originates in prescribers, and also physicians can have a major role in identifying and developing and distributing treatments for this problem. Okay, the methadone and buprenorphine are the bulk of the medication-assisted treatment options for opioid addiction. So there's also use of naloxone, but some people don't like that because it makes them feel anhedonic. So methadone and buprenorphine have been the mainstays. However, methadone has only limited availability, only in basically pain centers and also licensed opioid treatment facilities. So the buprenorphine has proven an effective alternative. Under the Drug Addiction Treatment Act of 2000, qualified physicians can take readily available short-term training. It's only about an 8-hour course online to treat opioid-dependent patients with buprenorphine in an office-based setting. So that makes primary care physicians active partners in the diagnosis and treatment of opioid use disorders. Now, primary care practitioners have a tough call because we have to differentiate between appropriate and medically indicated opioid use and pain management versus inappropriate or abuse or addiction. And also, physicians are under increasing legal scrutiny to prescribe opioid medications responsibly. I currently know a physician who's serving time from working in a pain clinic, although he didn't believe he was doing anything wrong. Practitioners have to be cautious to justify the use of opioids. But many, as Jonathan, who just presented, many of the cases of addiction I've seen have been caused or contributed to by uninformed physician prescribing practices. A lot of patients have been put on high-dose opioids for long periods of time, then abruptly discontinued, or their medications were discontinued before an underlying pain problem was resolved, and that drove them to doctor shopping or the streets. One of the questions that a primary care practitioner has to answer, a person may come to them for addiction treatment, certainly, but when they're dealing with a person who they identify a drug abuse problem, is it really addiction? Addiction is defined as continued substance use in the face of adverse consequences, and extreme compulsion is the overriding feature of addiction. For instance, a person gets arrested for drunken driving, their license is confiscated, but a couple of days later they're on the road again and drunk, and punishment is no deterrent. The key to identifying addiction is that it impairs the person's function. When a person uses a substance, function deteriorates, but the use continues. Dependence is very different. It's defined as a state in which the body relies on a substance for normal functioning. And an example of that would be a person with a ruptured disc in the lower back, and the pain is so severe they can't work or take care of their children. When they're given an opiate pain medication, the pain is reduced to the point where they can function normally and responsibly. The key to identifying dependence in terms of addiction medicine, other fields use different terms, however, but the key to, you can call it pathological dependence versus therapeutic dependence, or whatever you want to use it. But the key to that, you have to make a distinction between the person who the medication is aiding their function and the person who the medication is undermining their function. Now, tolerance and pseudo-addiction. Tolerance is defined as decreasing response to a drug over time. Increased doses are necessary to get the same effect. This is often confused with addiction. A patient keeps asking for more medication, but it's natural for a person to develop tolerance to an opioid medication. They may not be an addict just because they're asking for more medication. It may be that the medication doesn't work anymore at the previous dose. And pseudo-addiction is uncontrolled pain leading to behavior that superficially mimics the out-of-control conduct of the addict. A person may increase the dosage without the knowledge or approval of a physician. They may complain or lie to get more drugs. They may turn to street drugs or doctor shopping to get more drugs, but their problem is pain. I've seen a lot of people in drug treatment that when I try to identify why they're using the drug, they're actually in physical pain, and the drug-seeking behavior stops as soon as the pain is properly controlled, whether by medication or some other means. So we need to differentiate between true addiction, people who are benefiting from medication, and people who just aren't getting enough medication. I've seen sickle cell patients, I've seen multiple sclerosis patients who couldn't get the medications that they needed just because people were afraid of addiction, but their problem was really pain. So the primary care practitioner faces the task of trying to differentiate between a person who genuinely needs the medication and a person who's abusing the medication. We're going to talk about some ways to do that. Now, the primary care practitioner has to decide whether to treat or refer. If the patient is going to need methadone, they need to refer them to an appropriate treatment facility. It's effective, methadone is, but it's principally in pain clinics and specialized dosing centers that may be geographically distant from users, especially in rural areas. Some states have very few or no methadone treatment centers. Buprenorphine is much more widely available. It seems to be less subject to diversion because it has opioid blocking effects, and it's also used in combination with naloxone, so a person cannot use it intravenously to get high. It has a shorter plasma half-life than methadone, but it stays on the opioid mu receptor for a much longer time, so some people don't even need to take it every day, where methadone typically need daily dosing, and some patients with rapid metabolism need multiple daily doses. It also appears to be safer in pregnancy. You see less babies in withdrawal with neonatal abstinence syndrome with buprenorphine. But buprenorphine is not perfect either. Buprenorphine has ceiling effects on its respiratory depression. It's less likely to cause overdose, but if buprenorphine does cause an overdose, it's very difficult to reverse it because it stays on the opioid receptor so hard, it's hard for naloxone and other drugs to dislodge it. The side effects appear to be milder than methadone. It seems to be methadone can cause chronic sweat, constipation, sexual dysfunction, and they report less of those problems on buprenorphine. Chronic liver disease, however, is extremely common among injection drug users, especially hepatitis C. Methadone maintenance is proven safe for patients with stable chronic liver disease, even patients with cirrhosis, but buprenorphine, usually taken under the tongue sublingually, is associated with elevated liver enzymes, so liver function should be monitored during buprenorphine treatment. Neither methadone nor buprenorphine seem to affect the safety and efficacy of the treatment of hepatitis C, which is common in people who have shared needles, but both drugs have interactions with certain HIV medications. So if a person is on HIV medication, the practitioner needs to be aware of a possible interaction with methadone or buprenorphine. High-dose buprenorphine seems to be more effective than low-dose methadone in keeping clients in treatment, and also and also keeping their urine free of illicit drug screens. But buprenorphine may not relieve subjective symptoms for patients who have used large quantities of opiates for a long period of time. Even at high doses, buprenorphine only activates the opioid receptor about 40%. In severely addicted patients, the methadone, which activates the receptor 100%, seems to be more efficacious and keeps people in treatment better. I've heard from people who have used for a long time who have taken buprenorphine, they say it took away the withdrawal, but it never took away the craving, where methadone did. Pain management in buprenorphine can be challenging because of its very high affinity to the opioid mu receptor. When you try to give them other medications for pain, it may not be effective. The induction can also be challenging because the patient has to be in active withdrawal. If you take a patient who's not in withdrawal and give them buprenorphine, it may throw them into withdrawal. And there's an article on the bottom that talks about comparing methadone and buprenorphine. Since the slides will be available, you have this reference to look at to compare the two. Neither one is perfect, and they both have advantages over each other. So how do we decide? I said that a person can be an abuser, meaning that they're using casually, but they can stop. They can be dependent, meaning in addiction medicine that they just need the medication in order to function. They can be actually addicted, meaning that they won't stop no matter what, or it can be a false addiction due to uncontrolled pain. So there are tools that are available for monitoring chronic pain patients at risk. The self-report instruments, the prescription drug use questionnaire, physician assessment tools, the addiction behavior checklist, urine drug screening. There are specific tools related to monitoring opioid use in pain patients. The screener and opioid assessment for patients with pain, revised so far, the opioid risk tool, and a pain assessment documentation tool. And there are a number of articles that are references here that you can consult with in order to get more information. In the space of this time, there's no time to break them down and explain them individually, but they're tools that a primary care practitioner can use to figure out what is actually going on with the patient and what they actually need. But a purely pharmacologic approach to medication-assisted recovery is rarely, if ever, sufficient in cases of addiction. Under federal law, people receiving medication-assisted treatment and opioid treatment facilities such as methadone treatment must receive counseling. That can include forms of behavioral therapy. Some choices are cognitive behavioral therapy, which identifies and challenges negative thought patterns and behaviors, contingency management, which incentivizes positive behavior and punishes negative behavior, motivational interviewing or enhancement, helping the clients identify and build on what's important to them, and 12-step, which provides peer-to-peer guidance and report. The primary care practitioner is encouraged to seek a counseling modality for patients with substance use disorders to help develop their recovery skills. Medication alone cannot get a patient out of addiction, and I'm sure that the previous presenter would agree with that statement. Finally, recovery-oriented systems of care. Recovery-oriented systems of care are individual-centered, self-directed approaches to recovery that build on a sum total of recovery support resources in a community, including physicians, counselors, family, faith-based organizations, support groups, intimate social networks, community-based organizations, peer support, schools, workplaces, in order to provide flexible, culturally sensitive, and adaptive services, providing continuity of care for the recovery people and achieving and maintaining lifelong sobriety. Some SAMHSA-funded addiction technology transfer centers are a rich source of tools and resources for the primary care physician related to recovery-oriented systems of care. SBIRT is brief intervention and referral to treatment, and screening, brief intervention, and referral to treatment. And here are some articles that talk about the recovery-oriented systems of care that you can look up and learn more about. And with that, I'll conclude. Thank you.
And now with the physician, Mr. Jamar James.
Thank you, everybody who signed up to watch this webinar. My name is Jamar James. I am a certified peer support specialist and recovery coach out of Southwest Michigan, actually out of Kalamazoo, Michigan. I'm with a nonprofit organization called the Recovery Institute of Southwest Michigan. We're a peer-run agency. Peer-run not meaning that 98% of our staff here are individuals who are in active recovery from substance use with mental health backgrounds. You can have either or. We were established in September of 2006. All right, so some of the services and groups that we actually have here at the Recovery Institute, we host a number of them. We have peer support services, that's one-on-one peer support for individuals who have mental health and or substance abuse backgrounds. Recovery coaching is something that we do with individuals, and that's primarily for individuals who have that substance use background. Transformations group is actually a group that's built up for individuals to come in and lean on each other, build supports, share their own recovery experiences, and get some tools to help them go about their everyday lives. Smart Recovery Group is one of our more scientific-based groups. So there's the actual curriculum that goes along with that group. Helping Men and Helping Women Recover groups are groups that help men and women address some of the trauma that goes along with their substance use backgrounds and or some of the trauma that they've faced with their mental illness. So let's go a little bit more into what peer support services are. Peer support services assist individuals who basically are living with mental illness disorders and or seeking recovery, as I said before. Peer supports are individuals who we share our own experience of recovery from mental illness concerns, and we do this in order to give hope and assist others who are having similar struggles. Right now in Michigan, all peer support specialists, we are certified by the state. We receive many other trainings in order to provide peer support and in a safe and effective way for the people that we serve. One of the things that I learned in going through being a peer support and also receiving peer support myself is that recovery in some formats is linear, in other formats it's not. When I say that recovery being linear, there are many pathways to recovery, but everybody has that one thing that they find that pushes them towards that recovery. But everybody's recovery is different. Some things may work for me and work for another person, and then there may be things that work for another person that don't work for me. The journey in recovery is to figure out what those things are. With recovery coaches, we inspire people to overcome barriers to substance abuse and recovery based on their own recovery experiences. So we utilize our experience to enhance their own experience. We utilize our journeys, our travels to help enhance theirs. But their recovery is their own recovery. The only thing we can do is be a support for them. We truly believe that an individual is the best expert on their own recovery. We serve people as mentors. We foster their inner strength. We help people to move forward and rebuilding their personal lives. We can be their allies. We make sure we're truth tellers. We're honest with them. We try to be role models by distributing principles that we learned in our own recovery to help those individuals see that they can do those same things. We guide them. We help them with their problems. We try to solve them. But we also push for those individuals to be personally responsible for their own actions. We do resource brokering, and we advocate for them with other community organizations. So with the transformation groups, like I said, it's a peer-run group. We meet 3 times a week. It's made up of individuals who are in recovery, or they may be seeking recovery from substance abuse and or mental disorder. We don't discriminate. We try to meet people where they're at. That's one of the most important things you can do with a person who's even thinking about going into recovery, and a person that's thinking about stopping using, is to meet them where they are. You don't turn a person away because you have an idea of where they should be or where their mind should be at the time when they're even thinking about recovery. Smart Recovery is a science-based addiction support group where people learn self-empowering skills and support each other in their recovery. Helping Men Recover and Helping Women Recover, as I said, these groups address men and women's struggle with their lives, such as addiction, sexuality, and trauma. So some of our partner organizations that we work with. We have the local state-operated psychiatric hospital where we have a peer in there, and a peer that teaches a Smart Recovery group actually in the hospital and works alongside some of the hospital staff as well in some of their other programs. We have the psychiatric unit in the private hospital where individuals go up to a place where we call One North, and they visit people there and they talk to them about recovery and give them resources as well. We also work with our local psychiatric clinic. We also have a jail diversion treatment courts, recovery coaches working in jail diversion programs, working alongside judges, working alongside probation officers, working alongside the prosecutors to help individuals make it through those programs, but also to give them other avenues to recovery as well. We have a community day shelter that we work with as well. We go there and participate in some of the groups that they hold there for the people that come there. Neighborhood associations, we try to work along with our neighborhood associations. We're working on a project right now with one of the neighborhood associations where we can start actually offering one of our recovery groups at the association for the community, the surrounding community. Parades and recovery fair, we try to reach out to other organizations every year, and we have a recovery fair where people come together and hand out information about their organizations. We promote it on the radio. We promote it on one of our local channels here. We promote it on the internet, Facebook, and try to get the community to come out so they can learn about the resources that are in the community that can help those individuals who may be in recovery or thinking about getting in recovery, or if you have a family member who you feel needs an intervention or just doesn't know any information about recovery programming and the fact that there are peer supports and there are recovery coaches, individuals with lived experience, getting their lives back together, finding work, and pushing forward in their own recovery by helping others do the same. Colleges and high schools, we go and visit and we talk to individuals in high school, colleges, and other agencies and programs through a venue that is called the Power Group, and that stands for People of Wellness and Recovery. These individuals all have lived experience. They're in active recovery, and they go out and they share their stories of recovery with nursing students, therapist students, psychiatric students. They share it with high school students in different health class and venues. They do all of that, to fight the stigma that is pushed against those who have that substance abuse background and those who have a mental health background as well. But they do it to instill hope in others. There's a lot of individuals who go through things, whether they're kids in the high school who may be facing some of those difficulties with substances themselves, or it may be their parents and they just never had an opportunity to even talk with anybody about it. They see it every day, but they don't really know, where they could possibly get help from, whether it's help for themselves or help for their parents. The same with college students. Some of them suffer quietly with a lot of their substance use and the things that they go through. So the idea is to let them know that recovery is possible and there are other people out there that are going through some of the similar things and that they came out on top and are moving forward. So type of peer support people seek. Here's one of our slides. We actually ran the numbers to see how many people we actually serviced in a year and what mainly they asked for. So material support, as you see right here, is about 1%. You have the general skills sitting at 3%, physical health sitting around 3%. You got recovery planning sitting around 3%. Referral to community resources, that's sitting around 8%. Engagement is 13%. But the overall one sitting at 68% is the social and emotional support. That's what a lot of individuals who come to our agency are looking for, no matter what their genre is, whether they're here looking for help with their mental health or whether they're here looking for help with their substance use. Some of our classes in the attendance, like some of the choice classes. As you can see, like the men's healing group, we just started that group back up. So the numbers there are they're not bad, but hopefully they grow. It's 30%. We have women's healing. They're sitting at 53. You have the yoga group promoting good health through yoga and working out. It's one of the things that we do also here, sitting at 55. You have the smoking sensations group. As you see, that group is actually sitting at around 73. Our Rainbow Recovery group, that's for the LGBT community. That group is actually sitting at 184 we have here. You have our WHAM group, which is whole health management model. It's focused primarily on your whole health. It's not just one thing. It's what can you do for yourself, whether you're addicted to cigarettes, whether you need to work on your diet. It's just that whole health approach. We have the OCA group, which is for individuals with substance compulsive disorder. It's based off of a 12-step approach. And as you can see, that the numbers for that is around 235. You have our hearing voices, and that's for individuals who do hear voices. We have a support group where individuals can come and talk about some of the things that they experience. They talk a lot about some of the techniques that Ron Coleman himself uses. We also have the Transformations group, which is one of our bigger groups, and that's sitting at about 1,081 attendees. And our Smart Recovery group, which is our highest ranked group, and it's sitting at 1,616 attendees. So the number of people served, Kalamazoo population is sitting at 260,000. Kalamazoo City and Portage population is 124,492. And the number of people who receive peer support from us here at RI in 1 year is 1,630. So with that, that's kind of the end of my slides, and we can move on to any questions or answers after I hand the mic back to my representatives at the National Center for Primary Care.
The webinar presentation is currently available for download. That can be found in the pod in the lower right portion of the, lower left portion of the screen. The archived links to the previous webinars, parts 1 through 4, can be found in the web resources pod, and you're free to submit questions in the presenter Q&A pod. Our first question, and this question is for Dr. Banam and for Mr. James. What is the difference between recovery? What is the definition of recovery, and how does that differ from treatment?
Well, treatment is, the goal of treatment is recovery, and I would say that recovery is basically the person not having their lives dominated by the substance. A person who has had an addictive disorder is always going to be prone to having problems with substances. I've seen people who were who had stopped using a substance, for instance, for a long period of time, who went back to it after they used a different substance. I'm thinking in particular of a person who was using cocaine and recovered, but then drank alcohol and got drunk and then started using it again. So people are always going to have the underlying disorder when they have the problem of addiction. But a person in recovery learns how to stay away from the substance in spite of that. They basically learn things like, for instance, what are their triggers, what made them use in the first place. Was it some sort of emotional trauma like childhood abuse or something of that nature? They learn what led them to use in the first place. They learn to avoid the situations in which that they would be prone to use. They learn to respect the substance that, so many people forget that they've been out of it for a while, and they think that they're like somebody who's never used, and then they go on ahead and use it again and then lose control very quickly. They face the fact that if they use the substance at all, they're going to lose control of their use, whether it's drinking, whether it's opioids, whatever it is. But the person in recovery manages to function, manages to have a functional life, manages to have normal social relationships and fruitful social relationships, participate in activities that are enjoyable to them and fulfilling to them without using the substance. And I'd like to hear what Mr. James would define treatment versus recovery as.
As having experience in being an individual that's in recovery, I think that treatment is actually a tool of recovery. SAMHSA describes recovery as, from a mental disorder or a substance use disorder, as a process of change through which individuals improve their health and wellness live a self-directed life, and strive to reach their full potential. That's SAMHSA's definition. My own personal definition of recovery is just living the life that you want to live. You know, being the person that you want to be. For me, that was a big part of my recovery. It was me defining myself and not allowing any other individual to define me. The treatments that I received were all a part of my recovery. They were tools for me to use in order for me to be successful in my recovery.
Comprehensive answers. Our next question. How would you characterize recovery centers in urban versus rural settings? And do you believe the differences in these settings impact patient recovery?
Well, from my perspective, one of the problems with rural setting is that, you know, drugs are available there of various types. There's less knowledge about the dangers of using drugs there, but access to care is more difficult. But I'm speaking specifically of my experience as a physician who was using methadone and buprenorphine. People would have to drive very, very long distances to access health care in general. And methadone centers were very, very sparse around the state. In urban centers, there tends to be more resources available in terms of where people can go, you know, in reasonably short distances without the investment of too much driving and too much time. Whereas in rural areas, you know, actually finding treatment can be much more difficult. And but fortunately, with the advent, in regard to opiates, with the advent of buprenorphine, we have a lot of office-based practices that can at least address the problem of opioid addiction.
From my observation, I will have to agree with Dr. I don't want to torture his name, but Bonhami. I would have to.
Don't worry.
I'm sorry, but with the good doctor, I would have to say I agree with them with the rural, because we don't see a lot of people who live in rural areas come to our center. As far as in the community base, it's demographics. You know, it's about where you're located. We don't primarily see a lot of ethnicity as far as blacks and Latinos that actually come to our center. Some do come, but the majority of the individuals who we seem to help and service are of the Caucasian persuasion. But there's nothing wrong with that in the sense that this is where we're located. If anything, I would like to see more recovery-orientated nonprofits pop up in more urban areas versus just being in one spot, but being able to branch out. The more you're able to branch out, the more people you're able to reach.
I have a question specifically for you. Can you please discuss the importance of hope and accountability in treatment approaches?
So with hope, you want a person to be able to find something that gives them that drive to want to move forward in their recovery. I found hope in my son, my junior. That's where I found my hope when everything was dark for me. Me having that realization that I wanted to be the one that set the example for him. I wanted to be a true role model to him. I didn't want him to see me doing and displaying the same behaviors, attitudes, and actions that I've seen my parents doing. And me wanting to do that gave me hope. It gave me hope that I could be the one that broke the cycle so that he didn't have to break the cycle for his children. My hope was led forth by my son. When it comes to responsibility and personal responsibility, you want an individual to be able to accept certain things in their life. They've got to be responsible for themselves, be responsible for their actions, but you want to be able to get them to understand that some things that happen to them isn't their fault. And even though they may take some kind of responsibility for the part that they played in it, it doesn't mean that they're saying it's their fault. It's just them acknowledging that they needed to be more aware of what was going on at the time. That helps a person be able to move forward. I know that's what helped me be able to move forward. I know that's what helped a lot of individuals who I talked to over the years be able to move forward. It's just that acceptance. Accepting in being personally responsible for their own lives as they move forward in their recovery.
Dr. Banam, I have a question for you. What is the rationale behind the use of medication-assisted treatment to treat substance abuse disorders? And are there non-medication therapies which are equally effective?
There are certainly non-medication therapies that are effective, but the question is for which person? Some people, okay, let's talk about the opioid area and stuff like that. When a person is in heavy withdrawal, they're not capable of listening to any other type of modality of therapy, of talk therapy or something of that nature. I've heard a lot of people criticize medication-assisted treatment. They'll say, well, okay, the person is addicted to heroin and you give a methadone or buprenorphine, that's another opiate. That's like giving gin to an alcoholic. Well, not exactly, because if you gave gin to an alcoholic, they couldn't drive a car or function. Whereas if you give methadone to an opiate addict, they become able to function. And their function is improved. They don't have to chase the drug all day and all night. People say, well, they're both opiates. Yeah, well, a cheetah and a turtle are both four-legged animals. That doesn't mean they behave the same. Methadone gets in and out of the body much more slowly, so you can dose them at a point where they're not high and they're not sick from withdrawal. So the point is that medication-assisted treatment is the only thing that's going to work for some people. As a matter of fact, that was the way that methadone was discovered. In the early 1960s, a husband-wife team, Vincent Dole and Marie Niswander, were trying to treat heroin addicts, and they gave them everything in the book: morphine, Dilaudid, Darvon, Demerol, codeine, and they were just still getting sick and getting high. They tried the methadone as a last resort, trying to get them off all that stuff, and people started talking about, I'm thinking of painting again. I used to like to paint. I'm thinking of getting back to it. And they heard the addicts expressing outside interest when their need for the opiate was satisfied, but not to the point where they were intoxicated and not to the point where they were sick. They were able to function. The point is that rationale for medication-assisted treatment is either to get the person past the initial withdrawal of the drug, which might be just a detox, or to keep them on a maintenance dose where they don't crave the drug anymore and they can function as a normal person. So that's what the rationale is. And before we had modalities to medication-assisted treatment, there were a lot of people that we couldn't do a thing for.
Thank you. We will move on to our next question. As health professionals, how can we best address co-treatment? For example, treating opioid addiction along with nicotine addiction.
Well, both can certainly be treated. You know, if opiate addiction, some people who haven't used for a long time, you can successfully detox them, and you can awfully successfully. It's a good idea to address the nicotine or something of that nature, because tobacco-related illnesses are one of the biggest killers among methadone patients. People who are in the medication assistant. You can address both. Some of them you may need medication for, and some of them you may not. But they certainly can both be addressed, and successfully, by a lot of the same modalities that you would use for a person who is addicted to a single drug. As a matter of fact, in my experience, when I first started in the 1980s doing addiction treatment, people were very neatly compartmentalized into one type of user. You had your alcoholic, your marijuana user, or your cocaine user, or your heroin user. Now polydrug use seems to be the rule and not the exception. A person using cocaine might also use opiates or drink in order to meet the edge of the high. The point is that people using more than one drug seems to be the rule rather than the exception. So when you put a person in drug treatment, you try to treat everything, especially those things that are impairing their function.
Yeah, I would have to say that looking at it and taking it one thing at a time. If you have a person that's addicted to opiates and then you have a person that smokes cigarettes, primarily as a recovery coach, the thing that I would want to really address first would be the opiate use. I would want the individual to address that first. I mean, cigarettes are a crutch, and there is something that if a person really wants to get off of them, you can address those things. But I would want to say what's the good of the two evils. I would rather have a person smoking cigarettes than I would have a person taking that risk every day with using opiates and taking that risk of overdosing and ending their lives. The cigarette use is something that we could come back to later, but the opiate use, in my mind, would be the most prominent thing to address.
Absolutely. Whatever is impairing their function, that's what you have to address first. A person can function on cigarettes. They can't function on narcotics.
Wonderful. Our next question. How might buprenorphine utilization by primary care providers impact treatment outcomes?
The main way that I think that buprenorphine impacts treatment outcome is the fact that it makes opioid treatment much more accessible. Again, we have the issue of where, especially in rural areas and in certain states that don't provide methadone or provide it only in certain locales, you have people who are opioid addicted that really can't get to medication-assisted treatment, and they may be at a point where only a medication-assisted treatment intervention would help them. So buprenorphine being something that a primary care provider can prescribe makes opioid treatment much more widespread. One of the things also that methadone has a lot more stigma associated with. Some people, you say methadone, they think methamphetamine, but buprenorphine, a lot of people probably can't even say that. But at any rate, there's less of a stigma associated with it. So it's much more accessible. People can take it themselves by prescription. They don't have to go to a dosing center every day. The way that people in later methadone treatment, you can give people take-home doses when they prove that they're stable. But with buprenorphine, they can take it on their own. So it makes the impact of buprenorphine is to make medication-assisted opioid treatment much more widely available. And it's a tool that the primary care practitioner can use as well. When they find a person with a drug problem, they can do the buprenorphine induction and put them on buprenorphine. And so the primary care practitioner becomes an active arm in the treatment of opioid addiction.
Okay, wonderful. If you have anything to add, James, we can hold for that. If not, we can move on to the next question.
No, I think you answered it good. We can move on.
Okay, wonderful. Cheryl writes that House Bill 3692 permits nurse practitioners to treat opioid disorder patients. Additionally, the bill allows addiction treatment access to non-physician providers. Mr. James and Dr. Bonham, could this bill be a solution to the access areas where there is a shortage of providers nationally to treat opioid use disorders?
Well, I definitely favor things that improve the access to treatment, definitely. I worry a little bit about, nurse practitioners are under the supervision of a physician, but I do think that because these are medications that can be potentially fatal, that I think that a physician needs to be involved at some level, even if they're not the direct provider. Because if a person takes buprenorphine and then takes a benzodiazepine like Xanax on top of it, or just like with methadone or heroin or any other opiate, the combination can be fatal. Also, some people have conditions like chronic lung disease that you have to be very careful putting them on opioids because they can cause respiratory depression in a person who already has respiratory compromise. So I do favor, don't get me wrong, I favor physician extenders. I think that nurse practitioners, physician assistants ought to be able to do more, especially in areas where no physician is available. But I do think that ultimately some medical judgments have to be done by the physician. When we were treating people with methadone, it always required a full physical exam before we would do anything. And basically another thing we would do is a TB test because when you have people who are HIV positive, they're very prone to TB and you can't have other patients coughing around them TB germs. With buprenorphine, you have to monitor the liver enzymes because people who have liver disease especially can have liver damage from buprenorphine. So there has to be some medical supervision of those physician extenders, but I do favor the idea of anything that will solve the access problem because especially in rural areas, people just don't have access to any kind of treatment, and that's a tragedy.
I would think I would be in favor of the measure, but I would also want to know about the accountability and the training that's going behind it. I know when I worked on the ACT team, we had a doctor, and then we had nurse practitioners, we had case managers, and then we had peers and recovery coaches. And we always talked about the individuals before we even went out in the field to see them. Some of the interactions that we had with them was delivering their medications. They met with the doctor. They had their medications prescribed. The nurse practitioners did their work as far as, making sure the medications were ordered. Case managers and peers, we had something to go off of when we were delivering the medication, but we also had the training behind it. So we weren't just handing pills out. We actually had to have the training and know the milligrammage and know some of each individual's medical history. So it was something like that. Yeah, I would be for that if the person had the proper training, if it was actually a team effort and nurse practitioners weren't just going out blind.
One of the things, even as physicians, one of the points that I made in my slide is that it doesn't just work with medication. You need to collaborate with counselors to provide some sort of counseling and that type of thing. So even physicians need collaboration in order to address addiction disorders. So the point is, nurse practitioners can be independent, but I think in this instance they would need to collaborate with physicians, and we all need to collaborate with some sort of therapeutic counseling effort in order to successfully address addiction. I don't think that anybody involved in this would disagree with me that you can't just give somebody a pill or medication to drink and solve this problem. You need a lot more than that.
Definitely agree with you on that.
How can health professionals incorporate cultural competency into opioid recovery programs?
Now that is interesting, because I do think that a person who has a problem with addictive disease often has problems with trust as well. And I think that one of the things that I think can help with that is to have a peer-to-peer approach, to have people involved in the treatment team. And I think, again, this requires a team. There has to be collaboration, even if they're not in the same building, but people of the same ethnic, religious, cultural background as the person that is being treated. Now a person of a different cultural background who the patient or the client feels understands them can also be quite acceptable. But I think that also the way that I think you can incorporate cultural competency is to have some element of peer-to-peer in there. Somebody from the community or the same culture that that people know. Like for instance, Mr. James was talking about there's a group for the LGBT and that type of thing, that you basically try to hook people up with people who can understand them. Even if one practitioner is of a different background, at least somebody is there for them from the same background. I think that assists in the cultural competency question.
I have to agree with that. I think with cultural competency, it has to be something that's collaborative. That's the whole purpose of peer-to-peer, and it's the whole purpose of that movement. It's individuals who have that lived experience being able to share how they got to where they are with somebody who's looking to better their life that is in a position the other person once was. So I think, that collaboration is very, very, very important. But if a nurse practitioner is actually knowledgeable about some services that are in the community, somewhere where a person can go to get that help, if you can't personally give it to that person, then I think that would be beneficial as well.
Next question. Low-income urban African American communities have been left out of the 2017 conversation around the opioid epidemic. What methods have been found to be most effective within this population with regards to...
Well, it has not been my experience personally that low-income African Americans are left out of the conversation. I do think there's been a lot of emphasis on focusing on the opioid epidemic, since now it's in urban area, it's now in wealthy suburbs and things like that. We hear a lot about that. But I do think that in my experience, a lot of clients, I have had a lot of African American clients come forward. I do think that, again, to address it, I think peer-to-peer approach is probably the best thing. Having people in recovery, talk to the community about their experiences with it, what it's done for them and what recovery has done for them, and basically putting a face like the person that you're trying to reach on the problem. I think that's the way to bring them into the conversation.
I'll have to say that I haven't seen that personally myself. I do know that there are African Americans who suffer from opiate, abuse, opiate disorder as well. But the focus hasn't really ever really been on them. I would think that there's still more African Americans who are using substances such as cocaine and crack cocaine, and those things aren't very prevalent as far as in some sectors, even in some recovery communities, because it's a disorder that affects primarily blacks. Opiates is actually, a disorder that affects primarily white people. But I think to kind of try to get some results done, as I said earlier, having more places, nonprofit organizations like the Recovery Institute, and actually having them in those neighborhoods where those people are, where black people are. Black people rarely are going to leave their neighborhood for treatment and go to a neighborhood that's predominantly white, where they're going to feel uncomfortable. You have to bring the treatments to the people. That's how I see it.
I agree. A lot of it does come down to access.
Question. When considering building trust in a patient population, is mandatory drug testing an effective strategy when developing a recovery plan for a patient?
If you mean a patient in treatment, yeah. Well, first of all, with opioid-assisted treatments, let's say like methadone treatment, it's mandated by federal law that you have to test them at least 8 times a year. But I think that drug treatment is an important part of the recovery process, because without it, you don't necessarily know who's responding to the treatment. There's also a lot of denial associated with addiction, and a person who can be being treated, let's say, for a primary opioid disorder, may pick up another drug and say, okay, well, this is something different, so I don't have to, worry about using it. But it may actually be a drug that has interactions with the treatment. So the point is that I do think that drug testing is an important way of monitoring the patient's progress, of actually seeing if your treatment is working. Because if you just have them come in and dose medication, you don't necessarily know what the result is, because you only see them briefly. And the point is that they may be having problems, or other problems may surface. As I said earlier, in my experience in this era, polydrug use is the norm rather than the exception, is the rule rather than the exception. So testing them for a variety of substances and making them aware of how those other substances may affect their primary addiction is a very important part of treatment. So I would say yes, that's one of the ways of knowing whether you're getting the result from the patient that you want.
I would say yes, depending on the circumstance. If a person is in a court program, such as like a mental health recovery court, or another drug treatment court, or a family dependence court, I would say yes, that is essential for that individual's own recovery. It can help promote personal responsibility, and it could keep a person accountable. As with the Recovery Institute, us being a nonprofit and we offering these services, I don't see us doing something like that here, where we would drug test somebody to see whether or not they're in recovery, or if they've used. If you say to us that you're in recovery, we're going to believe that you're in recovery. Hopefully the principles that we teach you in the class, hopefully by us promoting self-advocacy, promoting personal responsibility, promoting truth, helps you come to that point where you're truthful with yourself and you get honest and you start really putting yourself into the recovery. We're here for anybody, whether they're actively using or they're looking for recovery or they're in recovery. So I don't think that would be very beneficial for us here, but I'm also for it if a person is going through certain programming to where they need that accountability.
Should President Trump have declared the opioid epidemic to be a national emergency, thus allowing additional resources to be allocated?
Well, it's definitely going to take additional resources to combat this problem, whether it's done by declaring it a national emergency or by some other way. That has to come about because it's not going to go away by itself. I mean, everything that I see in terms of the opioid epidemic frightens me more than what went before, because now we have fentanyl being made in laboratories, which is approximately 80 times more powerful than morphine and 40 times more powerful than heroin, and that's being made in illicit laboratories, as well as fentanyl analogs that are so powerful that you could die from even touching them. So the point is that now the opioid epidemic is more dangerous than ever. So, however, what the president should have done, or what somebody else should have done, it is going to require more funding.
I think that he should have thrown more funding at the opiate epidemic, but in declaring it like a national crisis, I would have rather have seen him declare all substance use a national crisis. More than likely, people are dually addicted. You know, some people who are addicted to opiates also have other addictions as well. You know, substance use can be very linear. You know, it doesn't just have to be one thing. In another job that I hold here in Kalamazoo, where recovery coaches go into the ERs, usually when a person comes in, they may not come in because of their opiate use. They can come in because they have too much to drink. And then once you actually talk to them, you find out that they are actually addicted to opiates, and they have had like 3 overdoses, and then it's like, okay, how can I help you in that area?
And that's similar to a point that I made earlier, that these days, and I think Mr. James would agree with this, polypharmacy is very common. The use of one drug is very, very common. The use of one drug seems to be the exception rather than the rule, in my experience.
Yeah, I definitely agree with that.
Fortunately, gentlemen, we are reaching the conclusion of our webinar. I've been having fun, but time has snuck upon us. So, Dr. Bonham and Mr. James, I'll ask you for your closing thoughts.
Okay, I'll begin. I think one of the biggest things that we need to do as a society is to move addiction from the realm of being something that we stigmatize to a mental health disorder, because that's what it truly is. You know, we used to think a lot of things that we used to think were just bad behavior or weak will are actually a brain disease. We now know more about how addiction works in the brain, and that it's in the survival parts of the brain, and that a person without treatment, without assistance, has very little chance of controlling it. So I think that we need to move away from, we talked about the deficiencies in the medical system somewhat, but I think we also need to address some of the deficiencies in the legal system to stop treating a lot of these things as crimes and treating them as illnesses. And I think that my charge was to talk about the role of the primary care practitioner. The primary care practitioner can help by careful prescribing practices in the first place, not even using non-opiates when it's possible to manage pain without opiates, and also by identifying people who are having problems and identifying them correctly. You know, some people think a person needs a lot of medication, so they must be an addict. That's not necessarily true. They might be tolerant. Some person might require a lot of medication because of severe pain. And we need to make a distinction between who is benefiting from the medications and who is not. And primary care practitioners can help identifying those people that need treatment and making decisions about whether to treat them themselves or whether to refer them to treatment, but always to include some component of counseling and a team approach, because just giving medication will not solve the problem.
My closing thoughts are that, you know, recovery is possible with the proper tools, proper supports, proper guidance. It can be done. I would like to see more collaboration within the system between doctors, nurses, peers, social workers, psychiatrists, counselors, that's geared towards individuals. I want people to be able to see that, they're not going to be criminalized. They're not going to be judged. They're not going to have their kids taken away from them because they have, a disorder. I'm with Dr. Boham that, it should be classified as a mental illness. It's a sickness, and only if you go through it do you realize what that sickness really is like. When you go through it, you realize that you're afraid to talk about it with people because you're afraid they're going to judge you. You're afraid they're going to stigmatize you. You're afraid that they're going to demonize you. And I would like to see as a society that we move away from that and we do put more money, more funding into treatment and helping people to garner supports and be able to get back to living lives that's worth living. Nobody's life is perfect, but that doesn't mean that a person doesn't deserve to live a just wild life.
Dr. Bonham and Mr. James for a truly engaging and informative presentation. And we thank each of our participants for attending today's webinar. Again, the webinar presentation can be found in the lower left pod on your screen. The recordings from the previous 4 webinars can be found in the web resource pod. And on behalf of the National Center for Primary Care, Morehouse School of Medicine,